wait, let me just highlight this. The pathogenesis here is that cilia is paralyzed, so they lose ciliary function. Okay, so I hope she stressed that. So make sure you highlight that. They lose ciliary function. If you lose ciliary function, you can't clear out the respiratory tract. Okay, so that's the issue. Then you all know what happens with the inflammatory response. Okay.
Someone's going to jail.
Oh, yeah.
What?
No, she said the
Somebody
cause common. She used it in the
Oh.
She was like, I got it.
No, when you said that, I was actually going to talk about.
The cops are here.
No, you know what I was going to talk about? What is it? Workers' comp. This is actually one of the things that fall under workers' comp sometimes. Because individuals do actually get these diseases from their work environment. So it is one of those worker comp issues. Now, these patients are usually symptom-free for up to 10 to 20 years with chronic exposure. So, and this is very true because I remember my stepdad, he worked in asbestos and pulling out from the pain in the, New Jersey, we have old buildings and pulling out, scraping the walls. So in any event, he was tested for asbestos even after he retired. They would still test him for it because sometimes these diseases don't develop until way later. So just please keep that in mind that these patients have to be continuously tested for this, and especially if they're working in that environment for years and years. So that should always be part of their physical. Okay. Now, late finding, as you go over this, hypoxemia called pulmonary. Okay, if not, it's pretty self-explanatory. Okay, chest x-ray doesn't show much unless the body starts to go through the inflammatory process, and you will start to see these infiltrates of the white blood cells and so forth. Okay, or just say the immune cells. And what they call a hazing appearance, okay, on a chest x-ray. So remember the x-ray I showed you before with the white appearance, and then sometimes it'll just look like someone took an eraser and just kind of went across it. Okay, so that's hazing appearance that occurs. Pulmonary functional test, ABGs are there. Treatment, stay away from the asbestos or whatever it is in the environment. Corticosteroids, bronchodilators, and give them oxygen if they're depleted of oxygen. Now, did she go into ARDS?
No.
That's where she stopped?
She picked up Patho.
She went to Pneumothorax and stopped. No. Oh, well, yeah.
Pleural effusion, I'm not going to go over. Pleural effusion is very simple. It's just fluid in the lungs. And it could be, it could just be fluid, serous fluid. It could be blood. It could be whatever type of fluid that can be in the lungs from trauma or any disease process. So there's not really much to say about that. Give me 1 second. Okay, I'm going to make this real quick and simple. ARDS, and then we have IRDS. Okay, it's basically the same physiology behind it, but the cause is a little different and treatment is a little different. Okay, so ARDS is acute adult respiratory distress syndrome. Where have you seen this before? We've talked, kind of mentioned it in a previous chapter. Very good, shock. Okay, so remember, it is a complication of shock. So sometimes when patients can go into a shock situation, and I don't know exactly what shock to describe, but it could be any shock. They could go into a respiratory distress. Okay. So we'll go over the pathology in a second. There's the incidents and so forth. You can read that. So the cause can be anything, really, with the ARDS. So they have severe trauma, sepsis, shock, fat emboli. But if you look at this chart here, it could be anything. Okay, so I would say put a star by this. Not that you have to memorize each and every one, but if you look at this, it'll make sense to you. Because all of these things are either a shock or something that's associated with a possible shock. Okay. So drug overdose, embolism. Now, so what happens here in the pathogenesis with these individuals? Well, I don't want to say two things, but a couple of things. They will have inflammation that can lead to pulmonary edema. So with this pulmonary edema that occurs in the lungs, okay, the inflammatory process will cause the capillaries to be leaky and build up a bunch of edema around that area. Okay. Now, when they have all this edema around that area, another issue that can happen is the fact that they can also have a lack of surfactant. Atelectasis, just to let you know that term, this is what we call collapsed alveoli. So this is when the alveoli collapse. Atelectasis associated with lack of surfactant. What is the function of surfactant that you remember from physiology?
Keeps the surface tension.
Okay, keeps the surface tension, keep the alveoli nice and plump, okay, and good for function. So, if we have a lack of surfactant, that's going to make the alveoli collapse, obviously now causing an issue with airflow, okay, or distributing air. Another thing that can also happen with the alveoli is that they can also undergo fibrosis because of the inflammatory process. So if we have any of these three, that's all not a good situation, which can lead the patient into a respiratory distress. Okay. So, most of this we kind of already went over. Injury to the alveoli, circulation, okay. Distributed oxygen, which we Now, the other thing here, okay, severe hypoxemia. Some of this you kind of know already. There was something else I wanted to say about this. Yeah, I'm going to show you that picture in a second. I'm going to show you that picture in a second. Some of this pathogenesis is just redundant, so I'm sorry if I'm scrolling through this, but you can read this out.
It's okay.
It's not a big to-do. You can read through it. So, clinical manifestations, early, sudden marked of respiratory distress. So they will start to appear or seem like they're in a respiratory distress, whether they have difficulty breathing, maybe wheezing, okay, or any type of sign or symptom that goes along with that, okay, dyspnea, shallow rapid breathing, and so forth. Okay. Late finding, they're going to have tachycardia and tachypnea, okay, and a hypotension. So with the hypotension, we know that sometimes that's also associated with the shock situation, hence the reason why it's sort of related as well. Intercostal and sternal retractions, okay, because of the fact of the shallow breathing that is occurring there, and cyanosis, which is always a late finding, so depending on the lack of oxygen that they're getting. Okay. Hallmark, they say, is hypoxemia refractory to increased levels of supplemental oxygen. Okay, so what does that mean? That means that if you're giving these patients supplemental oxygen, it's a possibility it will not increase. Okay. So I do have the numbers I want to give you. Give me a second. Find it. You should keep the oxygen level. I'm sorry, I'm looking at my notes. Okay, sorry. The goal is to keep the oxygen levels, if you want to jot this down, over 60 millimeters of mercury. The goal is to keep the oxygen levels above 60 millimeters of mercury. And when you do that, I think that's according to your book. I don't know if that's clinical. But
60 is below 80 is actually really bad still.
Okay.
80 to 100 is usually what they like.
80 to 100, that's in a clinical setting.
Right,
Okay. Your book says 60, and I'll confirm that because I think that's where I got the information from. It says 60 in the book? Okay. Let's just, for test purposes and purposes, let's just say 60 because that's what the text say, but even though when you get over there, it's going to take something different. Okay. So, in any event, the point is to just make sure you keep the supplemental oxygen levels above, okay, that mark. And the reason why is because you want to make sure if the oxygen levels are at that level, you want to make sure that they have the proper diffusion, okay, that's taking place. So, that's the situation with that. Okay, now, pulmonary functional testing are there, you can read that. Chest x-ray will show that diffuse whiteout appearance, and I think I have a picture of it. This is a slide of acute adult respiratory distress syndrome. So one thing I want to point out here, when you look at the alveoli, look at that thickness. Okay, so that's a lot of fibrosis. When you look at alveoli, remember it's supposed to be that simple squamous epithelium. It should never look that thick. Okay, never look that thick. Now, down here is that whiteout appearance that I was talking about. Okay, so it looked like someone took an eraser and just went across the x-ray there. And so this is showing you the amount of infiltrate that is happening in this side of the lung. Okay. So we just looked at that picture. Okay. So treatment. Treatment is oxygen, okay, which we kind of talked about already and went over the levels. Also fluids. Also identify the underlying cause. So if it's a shock or whatever's going on, you also have to treat that, obviously, because usually ARDS, from my understanding, is not just a primary thing, but it's usually secondary from some other condition, okay, that's going on with that patient. So you definitely want to treat the underlying issue here. The other treatments are any type of adequate oxygenation. So they do have different types of instruments, from my understanding. It can kind of give them pressure and open up the airway and give them air. Okay, so I'm not sure of all those high frequency type ventilations and things, but that's also part of the treatment, okay, that can be used. Okay, and there's that picture I showed. Okay, now IRDS. This is infant respiratory distress syndrome. Etiologies here, or even though it's more incident than etiology, but this is infants that are born with issues with a lack of surfactant, and to the fact that the alveoli will start to collapse in them, causing them ventilation type issues. So they do say they're high risk here, and I'm not going to go through each and every one of these, but just to kind of give you an understanding. Let's say if a mom is not getting proper prenatal care, okay, that it can possibly put them at risk, okay, or put the baby at risk for this. They say poorly controlled diabetes, which also goes under prenatal care. They say C-sections, second twin. I don't know about I'm not understanding the physiology behind the second twin. RH factor incompatibility, which you guys probably know about that already, but usually it doesn't get to that point. And again, this also goes with prenatal care, because if the mom's getting proper prenatal care, she would know if she's RH negative in that whole situation. So just to kind of go into that. Okay, so primary cause is lack of surfactant. Again, we already know what the lack of surfactant is going to do. Okay, so I'm just kind of breezing through this. It can generate intrathoracic pressures to maintain patent alveoli, which means the alveoli will actually just kind of get, I don't want to say in a stuck position, but sort of in a stuck position where they won't be able to expand and have that type of crossing of the oxygen, carbon dioxide crossing as they should, which will decrease, which causes a decrease in lung compliance. So the other thing here is, yes, they will have acidosis, atelectasis, which is again the collapsing of the alveoli, which we know is because of the lactic surfactant. The other thing here, which I want to go over, yes, blood supply will cause an issue because of diffusion, which we know. I'm sorry, I'm breezing through this, but it's just talking about inflammatory stuff that you should know. Okay, so capillary permeability, yes. One thing I wanted to go over, which I don't see yet on the slide, is that, have you ever seen babies, and I'm quite sure you may have seen this, especially those of you that work in the field, where they kind of have this, I think they call it seesaw breathing, where the chest cavity just looks like it's going to jump out of the baby. This is babies, from my understanding, that do undergo that respiratory type of distress syndrome where it's sort of like an altered breathing that they have because of this.
Seesaw breathing is a chest and abdominal.
Chest and abdominal, so it looks like it's jumping out,
Yeah.
like the chest,
Yeah.
okay. Now, they also have flaring of the nares. I would also highlight that also to help with assisting in the breathing, okay, in that situation. Hypotension and so forth, so you can read that. Frothy sputum can come later on. Oh, there it is, the seesaw breathing. Yeah, here it is. Seesaw breathing with the chest wall. Okay. Now, diagnosis here, we know what ABGs are going to look like, and chest x-ray, they will also have the same whiteout appearance as the ARDS, okay? Now, diagnosis here is different than adults, where they do have something through amniocentesis that can detect if these infants are going to undergo this type of lack of surfactant situation. So with amniocentesis, and I'm quite sure you know what that is, when they take out the amniotic fluid, and so with that they can test for something called Lesigen-Sphingomyelin ratio and desaturated phosphatidylcholine. Say that 4 times. Okay. Now, basically what that is, that's just a fancy way of saying that if they look at this ratio, this tells us how much surfactant this infant is going to produce. Okay. So if they can see this ratio, they can determine, okay, how much surfactant, and then make a determination if they're going to have this respiratory distress situation. So the treatment is, if the infant is born with this or having this issue, giving them oxygen. And then also they can do exogenous surfactant. I believe this is administered through injection. I'm not sure.
They take it in a syringe and they put it down your breathing tube.
Oh, they put it in the
And
breathing
they
tube.
Squeeze that bag and it kind of aerosolizes out through the lung.
Now, do you know if they use more of a synthetic type?
Bovine is.
They use the bovine one mainly. Okay. Okay. So, and that is, I think, one of the main treatments that they say that usually helps with that situation. And then they can also do different types of ventilation type procedures for it. Antibiotics. Okay, for infection is, and also supportive care with food, electrolytes, and nutrition. Okay. Now, did she go over pneumothorax? Because you said she skipped to it. Okay. So you know what pneumothorax is. Okay. Did she show you the picture?
The tension
Yeah, picture that's on the slide.
Did she show you this X-ray?
No.
Okay.
When she was doing her little thing, she said it's right side tension pneumothorax, but I know the caption says it now. At least that's what I wrote.
No, that is a right side.
Is that the same thing?
Yeah, this is right-sided tension. So the pneumothorax is happening on the right, hence the reason why the heart is shifting to the left. Okay. So does everybody understand what happens with pneumothorax? So say, for example, let's just use a tension pneumothorax like a trauma. Somebody has a stab wound to the chest or whatever. When the pleural cavity fills up with air, it will actually cause now the lung to collapse. Okay? When the lung collapses, it will actually now cause a lot of tension and pressure on the mediastinum. Mediastinum will now start to shift, which can shift the heart and even the trachea. Okay? So even all those contents can shift over to that side, hence the reason why this X-ray looks like this. Okay. Keep in mind too that sometimes, and I don't think she went over this, sometimes patients with emphysema can also get into a state of a pneumothorax because they do have what are called blebs. Did she go over the blebs?
Yeah.
Yeah.
Okay, and those blebs can burst and cause the air to fill up in the pleural cavity and cause this situation. Okay, does everyone understand that? Okay.
Maybe you just might want to clarify too, because she was, I didn't want to interrupt her, but I interrupt you.
That's okay. I don't mind you interrupting.
She was saying that a spontaneous pneumothorax is caused from trauma, but it's not. It's caused
No.
It's caused from a bleb or something.
Yeah, spontaneous, let me clarify that. Spontaneous pneumothorax is caused by a bleb or a bulla, whereas a tension pneumothorax is from a trauma.
Right.
Okay.
spontaneous
Well,
and trauma.
Yeah, and the spontaneous can turn into a tension if it gets big enough.
Usually
So,
trauma.
But the reason I'm saying the main cause of a tension is trauma, the main cause. But yes, it can lead into a tension. Okay, is everyone okay? I know everybody's just tapped out. I understand. Is everyone okay in understanding what we're doing? Please study for next week 36. 22 and 23, you will be getting an email from me, and I'll give a full instructions as to what you should be doing for your take home. And also,
It's spontaneous.
I will
It's not trauma.
also send you an email to let you know what slides I'm covering next week. Yes, it is crunch time. And so what's going to happen is I'm going to pull certain diseases from chapters that I'm just going to focus on and highlight. Okay, just those. So I don't want you to feel cheated, like you're missing out.
now,
But I'm going to make sure I pull out the main common, most common disorders.
well, we appreciate that.
Okay. Can you turn that on? Thank you so much.